Good morning, everyone. So today's talk would be on hypersensitivity reactions. What are the different types of hypersensitivity reactions? And a few questions. So before that, we will try to learn about what is the definition of the hypersensitivity. Hypersensitivity is defined as an exaggerated or inappropriate state of abnormal immune response with onset of adverse effects on the body. The lesions of hypersensitivity are a form of antigen-antibody reaction. So these lesions are termed as hypersensitivity reactions on the immunological tissue injury, of which four types are described like type 1, 2, 3, and 4. Depending upon the rapidity, duration, and type of immune response, these four types of hypersensitivity reactions are grouped into either delayed or immediate types. So immediate type, as the word itself tells, which is on administration of an antigen, the reaction occurs immediately within seconds to minutes. So immune response in this type is mediated largely by humoral antibodies, that is B cell mediated. And immune type of hypersensitivity reactions would include type 1, 2, and 3. Delayed type, as the word itself tells, yes, the reaction is slow in onset and develops within 24 to 48 hours, and the effect is very much prolonged. So it is mediated by cellular response as prolonged as 14 days also. And it's mediated by cellular response, it is T cell mediated, and it includes type 4 reaction. So immediate is B cell mediated and delayed is T cell mediated. Immediate is type 1 to 3, delayed is type 4 hypersensitivity reaction. So before entering into these hypersensitive reactions, what are the characteristic features a hypersensitivity disease should categorize? So it is elicited by exogenous antigen or an endogenous self-antigen. So if it is an exogenous antigen, obviously we would give to us, the etiology would be an allergy. Okay, allergic factor. Whereas if it is an endogenous origin of antigen, then I would call it as a self-antigen, which is trying to create an autoimmune process and results from an imbalance between effector responses and control mechanisms which limit these responses, and associated with an inheritance of susceptibility genes and mechanisms of tissue injury are the same as those mounted against the infectious agents. So broad classification of these mechanisms of hypersensitivity reactions would be type 1, 2, 3, and 4. Immediate type of hypersensitivity is type 1, antibody mediated is type 2, immune complex mediated is type 3, and cell mediated would be type 4. So what are the different immunological mechanisms? What are the different histopathological lesions and prototypical disorders? We'll see in the further slides. So this is coming to the first type 1 hypersensitivity reaction. Yes, type 1 hypersensitivity reaction is an immediate type, as you all know, and it's also called as anaphylactic or atopy reaction. It's defined as a state of rapidly developing or anaphylactic type of immune response to an antigen, that is, allergen, to which the individual is previously sensitized. So this reaction occurs within 15 to 30 minutes of an exposure to an antigen. So etiology contributes for the humoral antibodies. As I have said, that is the B cell mediated. Obviously, you'll have the humoral antibodies. So these humoral antibodies have been mediated with help of this IgE type getting increased, that is increased IgE response, or a reagent antibodies in response to the antigen. So following hypotheses have been proposed for this type of hypersensitivity reaction. That is, the first is a genetic basis. Ability to respond to an antigen and producing IgE related antibodies are both linked to the genetic basis. For example, there is a 50% chance that a child born to the both parents who are allergic to an antigen may have a similar allergy. And further support this hypothesis will come from the observation that higher levels of IgE in hypersensitivity or hypersensitive individuals and low levels of suppressor T cell activity will control the immune response, and which that will control the immune response are observed to be seen in the persons which are having HLA types, especially the HLA-B8 type. And the second possibility of the hypothesis would be because of any environmental triggers, that is the pollutants. So another proposed thing is an environment pollutants, which increase the mucosal permeability, thus allowing the increased entry of the allergen into the body, which in turn leads to raised IgE levels. And third hypothesis could be an alternate hypothesis, which is contributing for the allergic response in type 1 would be linked to simultaneous occurrence of certain viral infections of upper respiratory tract in a susceptible individual. So pathogenesis is type 1 hypersensitivity reaction includes the participation of B lymphocytes, plasma cells, mast cells, basophils, neutrophils, and eosinophils. So the underlying mechanism as drawn here would be first the contact of the host with the antigen, then sensitization takes place. So in response to the contact with the antigen, the circulating B cells get activated and they differentiate to form the IgE secreting plasma plasma cells. T-secreting plasma cells will therefore increase the number of IgE antibodies so formed. So binding to the Fc receptors present in plenty of the surface of the mast cells and neutrophils, which are main effector cells of the type 1 hypersensitivity reaction. Thus, these cells will now be fully sensitized for the second event. So when the second event is triggered by the same antigen or during the second contact with the same antigen, IgE antibodies on the surface of the mast cells, basophils, are so firmly bound to the Fc receptors that it sets in the cell damage, membrane lysis, influx of the sodium and water, and as well as degranulation of the mast cells, as well as the basophils. So these are the different cytokines which are produced by these cells, that is macrophage activation and simulation of the IgE production and the activation of mast cells as well as eosinophils and recruitment of the neutrophils. So post defense would be if there is any intracellular microbes triggering this action, or if there is any helminthic parasites triggering this action, or if there is any extracellular basic of antigens, then the T helper 17 will be activated. Okay. Yes, so as I've said, the type 1 hypersensitivity starts with an exposure to an allergen, is the first exposure. Yes, and this dendritic cell is an antigen presenting cell, will be presenting it to the B cells. So these cells are the naive T cells which are very much immature, and the T helper cells will get triggered, and then they try to help these B cells to get the immune response activated. So activation of the T helper cells and IgE class switching in the B cells is being seen over here, and there is complete production of the IgE cells, that is IgE secreting plasma cells. The binding of these IgE cells onto the Fc receptor on the mast cells and the basophils, and whenever you have, this is called as a sensitization phase. When you have the second phase of contact with the same antigen, that is called as an effector phase. With the repeat exposure to the allergen, you have the activation of the mast cells, that is the release of mediators in the form of immediate mediators, that is immediate hypersensitivity reaction and the late phase hypersensitivity reaction. Immediate hypersensitivity reaction is when you have the release of these vasoactive amines, lipid mediators, and this hypersensitivity reaction occurs within minutes after the exposure to the allergen. Whereas in the late phase reaction, it occurs at least 2 to 24 hours after the repeat exposure to the allergen, where the cytokine release is maximum. So this is the way in which the mediators are being released with the help of degranulation from the mast cells and the basophils. All the granule contents like histamine, proteases, membrane phospholipids like arachidonic acid and platelet activating factor, releasing this arachidonic acid metabolites will be releasing the prostaglandins and leukotrienes, which will aggravate or trigger the immediate response in the form of vasodilatation, vascular leakage, and smooth muscle spasm. Whereas late phase is being contributed by the cytokines and the chemokines, and therefore you'll have this leukocytic infiltration, epithelial damage, and bronchospasm. So this is a flowchart depiction of what is happening exactly in the type 1 hypersensitivity reaction the moment the antigen tries to enter into our immune system. So this is the entire thing, which is an immediate response as well as the late phase response of what's happening after the second phase of contact of the similar antigen in the effector phase. So the effects of these agents would be increased vascular permeability, smooth muscle contraction, as I've said, smooth muscle spasm will be happening, and early vasoconstriction followed by vasodilatation, shock, increased gastric secretion, increased nasal and lacrimal secretions, increased migration of the eosinophils and the neutrophils at the site of local injury, as well as the rise in the blood circulation or the peripheral circulation, contributing to eosinophilia and neutrophilia. So the examples for this type 1 hypersensitivity reaction would be depending upon the severity and intensity. It may manifest as local irritant and sometimes may be severe and life-threatening anaphylaxis also. So common allergens which are trying to incite this local or systemic type 1 reaction would be systemic anaphylaxis, like you have any administration of anti-serum like anti-tetanus serum, or any administration of drugs like penicillin, or any sting by wasp or bee. The clinical features of the systemic anaphylaxis would be itching. The patient will be presenting with itching, erythema, contraction of the respiratory bronchioles, there is spasm, diarrhea. Okay, then the pulmonary edema, hemorrhage, pulmonary hemorrhage, shock, and even succumbing to death. Local anaphylactic reactions would be like hay fever due to the pollen sensitization of the conjunctiva and nasal passages, bronchial asthma due to allergy to inhaled allergens, or else food allergy like fish, cow milk, and eggs, cutaneous anaphylaxis due to contact with the antigen with the skin characterized by urticaria, wheal and flare, and angioedema, which is an autosomal dominant disorder characterized by laryngeal edema, edema of the eyelids, lips, and trunk. So examples will be anaphylaxis because of any drugs or any bee sting or any food allergy, or bronchial asthma, rhinitis or sinusitis by hay fever, or any food allergies. And the respective clinical manifestations would be fall in the blood pressure by vasodilatation, and even airway obstruction due to laryngeal edema. In asthma, you'll have the obstruction by the bronchial smooth muscle hyperactivity. Then, because of any hay fever sort things, then you have an increased mucus secretion and inflammation of the upper airways. And if you have any food allergy, there'll be an increased peristalsis due to contraction of the intestinal muscles. So, now as in summary, the early phase and the late phase and the different types of granules or the mediators being released out from at different phases is being depicted in this entire chart. That is atopy, where you have the susceptibility to develop the immediate hypersensitivity reactions with the help of increased IgE production. And the common allergens will be environmental, food, or any medications. And even desensitization can be done for these patients when they have this reaction with the help of antigen, chronic administration of the antigen, which is preventing the reaction. Then afterwards, the same thing. The pathophysiology is first exposure and the second exposure, where you have the release of the degranulation in the form of early phase mediators and the late phase mediators. And all these vasodilatation, leakage, gland secretion, histamine production, proteases apparent. Whereas in late phase, you have the cytokines and chemokines released, and eosinophils will be coming and recruiting to the site of action. Okay. And wheel and flare reaction, as you all know, allergy skin test. Yeah, we'll be seeing this. In asthma, as you all know, this hyperactivity will be seen. You have all this inflammation and all the mucus production will be increased. In skin, you have this eczema, hives, and all this rhinitis, and systemic anaphylaxis in the form of bronchoconstriction or even hypertension shock. Coming to type 2 hypersensitivity reactions, they are being nothing but having the participation of complement system, tissue macrophages, platelets, natural killer cells, neutrophils, and eosinophils, while the main antibodies here would be the production of IgG and IgM class. So these are especially meant to be tissue specific. When compared to type 3 hypersensitivity, they are not tissue specific, but type 2 is always tissue specific. And the reaction occurs after the antibodies bind to the specific antigens. Most commonly, the classical cells here would be platelet cells. So the mechanism here involved is the target cell, that is on the surface of the target cell, the foreign cell gets attracted and binds to the FAB portion of the antibody, that is IgG or M, forming the antigen antibody complex. Whatever is the unattached portion, it will form a link between the antigen as well as complement system. So the antigen antibody binding with the FC forming a link causes the activation of the complement system's classical pathway, thereby releasing the activated complement components like 3B, splitting the 3B into 3, 4, and C2 by C1. So activated C3B will bound to the target cells and act as an opsonin. So opsonin here is nothing but something called as opsonization, that is making the cells more tastier, so therefore attracting the phagocytes to the site of cell injury and initiating the phagocytosis. So antigen antibody complex also activates this complement system, exposing the MAC complex, that is membrane attack complex, which is nothing but formed by C5b and C9, which will completely attack and destroy the target cell. So these are the different steps which are involved in type 2 hypersensitivity, that is opsonization and phagocytosis, complement and Fc receptor mediated inflammation, and antibody mediated cellular dysfunction. So as I've said, the main cells which are being triggered in type 2 hypersensitivity would be our blood cells, hematological cells. That is, cytotoxic antibodies are being released to the blood cells, where you have the classical examples of autoimmune hemolytic anemia. Yes, then transfusion reactions because of any incompatible or mismatched blood transfusions, hemolytic diseases of newborn, erythroblastosis fetalis, immune thrombocytic purpura, leukopenia with agranulocytosis, or any drug-induced cytotoxic antibodies when you have this allergy towards penicillin, methyl, or rifampicin, and any cytotoxic antibodies to tissue components where you have, like, so for example, your Graves' disease, which is called as primary hyperthyroidism. The autoantibody is formed which reacts with the TH receptor and causes a hyperfunctioning and proliferation of the hormone. Then in myasthenia gravis, you have an autoantibody or the antibody to the acetylcholine receptors of the skeletal muscle, and therefore it will block the neuromuscular transmission at the motor end plate, resulting in muscular weakness. So this is a diagrammatic representation of Graves and myasthenia gravis, at which level the antibodies are being formed and how is it obstructing the further transmission. In male sterility, in type 1 diabetes mellitus, in hyperacute rejection reactions, and Goodpasture syndrome also, we see this type 2 hypersensitivity reactions. So as a summary, yes, The type 2 hypersensitivity reactions, especially the blood cells, like affecting this red cell membrane proteins like autoimmune hemolytic anemia, then autoimmune thrombocytic purpura, pemphigus vulgaris, Goodpasture syndrome, myasthenia gravis, Graves, and pernicious anemia.